And our main focus for today's meeting will be walking through the National Colorectal Cancer Roundtable playbook for reigniting colorectal cancer screening as the COVID pandemic continues. And so before we launch into that, since we have a few minutes, I'm just going to share a few opportunities that we have coming up, and all of this information I'll also send out in the follow-up email, so you don't have to take notes of dates or anything unless you want to block time on your calendar right now, but just wanted to let everyone know that we just scheduled a family history screening tool webinar for Monday the 21st, and that will be from 11 to 12 a.m. That one will really be focused on going through the updates that were recently made for the family history screening tool that we've been implementing with a few of our CCSP clinics to really look at familial and genetic cancer risk in the general population, general adult population. And so every year we go and do an annual review of the tool with our medical advisory board, which is composed of members in Colorado, clinicians, as well as those across the United States. And so Heather Hampel, who is a genetic counselor based out of Ohio State University, will be our guest presenter for that. She was very integrated in the process to update the tool this year, and so she'll share the current version of the tool and some thoughts and perspective about implementation. And so we really encourage the clinics that are implementing the tool to attend that webinar, but we also will have it open to everyone of our CCSP clinics and partners. And so if you have interest in looking at familial and genetic cancer risk and screening opportunities, we'd love for you to join us for that. And we will also record it and send it out and put it on the CCSP website. We're currently getting the updated version of the family history screening tool up on the CCSP website, and we'll also put up our guidebook that has some good tips and tricks if you're thinking about implementing a family history screening tool in your clinic system and for navigating patients through that process. So that's one opportunity that we have coming up. Also wanted to highlight that for navigators that have experiencing working with people who are experiencing homelessness, there is currently an opportunity available that Andy is helping lead out with the Patient Navigator Training Collaborative, a grant that really has some funds to look at experience of navigating those individuals who are experiencing homelessness. And so they're currently setting up interviews and focus groups with navigators to hear a little bit about the experience and support needs for those patients. And there is a little bit of money available for those who are willing to participate and have the experience of working with those populations. So if you have any experience working with people who are experiencing homelessness, I'd really encourage you to sign up for that opportunity, and because your perspective is needed, and trying to get a wide range of perspectives from different settings and across the state. So that will also be included in the follow-up as well. And then also just a couple of other opportunities coming up. There was going to be a Colorado lung cancer screening symposium in August. Because of COVID, that did not happen. So the Colorado Cancer Coalition and National Jewish Health and a couple of other partners are going to lead a web series in the fall on lung cancer screening. And so this is open to everyone who has an interest in building or expanding lung cancer screening in your institutions. And so whether you're hospital-based or just standalone primary care, there will be some different opportunities to talk about launching lung cancer screening and best practices, quality improvement for patient tracking, follow-up of abnormal findings, shared decision-making, smoking cessation, and then other priority topics that are connected to lung cancer screening. So I'll also send out the registration for that. And the first one will be on Friday, October 2nd. And so also I've had a few clinic systems recently send me some different opportunities or resources that they know of in relation to cancer screening uptake as it relates to COVID, and other resources for helping reduce barriers and improve access to care for patients during COVID. So we've gotten a few questions about trying to connect patients to resources. And if you know of any resources, we've gotten some really good ones. So if you have any, we would love to see those. And so those are the main announcements of things coming up at this point. If you know of any other events that you'd like us to share with the whole CCSP network, we're happy to do that as well, whether it's an event happening at your organization or something that you thought would be really relevant, please send that to me. And again, all of that information that I just talked about will be going out in our follow-up notes. So I'm going to turn it over to Andy to talk a little bit about Lori Workman retiring now that we've hit that point, and Dennis Onen, and any other announcements as we transition into the next piece.
All right, awesome. Thank you, Elsa. And it's great to see so many people on today. I'd like to share, and I think many of you know from our session, Lori Workman has retired, so it's a sad day. This is the official first day she's not working with us. The Cancer Center sent out a nice communication about Lori, and I took a screenshot and sent it to her and told her she was Facebook famous, and she said, "Tell everybody hi, I can't talk yet because I'm still so sad." So Lori did amazing work with us. I know she has sent communications to most of the fiscal folks, managerial folks about where to submit invoices and how to really keep up on the fiscal and financial side of the program. If you did not receive that and need that information, Elsa and I will send that out in the notes. And just a quick point, Lori was really such an internal program champion. She knew the program in and out. So for barrier reduction questions, questions about other aspects of billing, and needing quote unquote approval, Lori helped and was really as much of an expert as Elsa and I. But the new folks who will be processing invoices and working with us in the Cancer Center are strictly financial and business folks. So if you have questions about reimbursement, if you have questions about barrier reduction fund, anything that would require someone from the programmatic side to really know and to give guidance, that should come to Elsa and myself. So probably best to address it to me. Copy Elsa, we'll send this in the notes as well. So it's a little bit of a different process, but what I will say is the folks at the Cancer Center who will continue to support us have been in training with Lori Workman, and they've told me that Lori has already started checking their homework a day in. So I know she's giving good advice and counsel to them about how we really need to address the fiscal component so that you're all reimbursed in a timely fashion. So we'll send those communications going forward about how, and if you have any questions or aren't getting things reimbursed in a timely manner, let us know. But they're a pretty great team at the Cancer Center, and we're excited to have them. We will continue on just from a grant standpoint. We are still awaiting to know if we will be awarded that extra year just to get on sync, and if what the requirements might be. We're still probably a month and a half, 2 months out from knowing, but we have assurance that we will be funded if there aren't any other weird pitfalls this legislative session until the end of June 2021. And so what I want to say, and I think we've stressed this, and we'll be talking a little bit about how do we reinvigorate screening as much as we can with some tools that have been developed. Today we'll be talking about that, but screen, screen, screen. Sky's the limit right now. We're asking people to be pretty much on target with what their allocations have been over the last couple of years. But let me just say, the faster we can get people in and screened, the better, just in case if we see a surge with flu and cold season coming, if we see other limitations, we have a window of time that if we can do anything to support you to help really get your patients in for screening, now is the time. So we are not going to be looking at redo of scope of work until we know more about the overall fate of the program, if we are going to get that extension year or not. And then we'll make some decisions about asking for direct support for FIT and FOBT programs, more education and awareness, and some other aspects that we've heard when we've chatted with all of you. But we're in a bit of a holding pattern just right now, so more in touch there. But we're really excited again to have this opportunity. We and all of you have fought hard to keep our funding over this last grant cycle, and more than ever, we need to make sure our patients are screened. The other thing I wanted to mention, and I believe all of the connections have gone out through our, holy wow, sorry guys, people are just blowing up my email right now, so I don't know if you heard all those dings, but I apologize. The Dr. Dennis Onen, who is a longtime advocate for our program, who was actually one of the people who helped design our program at the beginning with myself, Lori, and several others, did pass away about 2 weeks ago from appendiceal cancer. Dennis was a huge champion. He is the one who really gave us a lot of good medical advice, connected us with national leaders around the work, and really helped elevate our work. He will be very much missed. So I just want to say a huge tribute. Anyone who knew him, he was a natural teacher. He was a great guy. He was a gastroenterologist, but he threw great parties. He was just a really good person, and he was amazing to patients, and health equity was really at the cornerstone of the work. And so I just want to give a nod to Dennis, because he was really our fearless leader, and it's really been a tough time. We will be sharing information about Dennis's memorial service in early October for anyone who knew Dennis and wished to attend. So more information to come. And the other thing I just want to mention is, I think in light of Chadwick Boseman's death and really thinking about that nexus of what's going on with health equity, and in light of COVID, CCSP is a program that is about working with the medically underserved, but it's really supporting all of you who are on the front line. And so I just want to say thank you so much for all of the great work you've done. I know that it's also a huge time for us to really think about what's happening in our country related to health equity. So as much as we can do to support all of you in this effort that you're working with, folks, we truly do care about you and the work you're doing. So it's just been a really tough, a really tough couple of weeks, but thank you guys for all of the great work. Elsa, do we have anything else in terms of update before we move to some of the tools and resources from the NCCRT?
I think we covered everything for the moment. If we have time at the end of the call, would love to get people's perspective, as I mentioned, about the different training opportunities you'd like to see and sustainability focused opportunities this year. And I'll also put out a survey link in the chat about please fill that out with your thoughts about sustainability planning for this year. We have met with most clinics individually, but would love to get some perspective about technical assistance and opportunities for cross-pollination and collaboration of ideas and brainstorming. And then we're also, now that we're in September, right at the end of our September is the last month of the first quarter of our new fiscal year already, coming so fast. So please, in that evaluation, also do the quarterly evaluation of these monthly calls, and a reminder that to make sure you have your evaluation data for the first couple months of the year completed in Qualtrics, if you have not already, for July, and we're coming up on September 10th for August data. So those were my last things for this moment, and I'll pull up the toolkit, Andy, unless you'd like to pull it up on your screen.
No, that would be great if you could. So everybody, while Elsa's pulling that up, the other thing, and I think Elsa might have mentioned it, but we've sent some communications. The Patient Navigator Training Collaborative has been funded by the National VA to do some examination of working with people who are experiencing homelessness or at risk for homelessness. If you have, if you are navigating in this role for people who are in rural, urban, people who are couch surfing, people who have issues with chronic shelter and like securing shelter in home. We would really love to hear more about your experience. The VA is launching a big initiative to help with navigation dedicated to the VA and homeless and those who experience homelessness. So this is really exciting. The PNTC has an opportunity to help do training and share. We do have some funds that if you provide interview, are willing to help review any of the modules, that working with them, we can help make sure that you or your organization have some compensation for time. So I think Elsa has sent that out a couple times, and we've sent that out through the Alliance. If you're interested, we have a short window for this first segment. We have something over the next couple of weeks that I'd love to spend some time chatting with you. So again, please let us know. And again, we'll send that out in the summary response today. So we're going to take, moving into the content part of the show, we're going to share a little bit about a resource that's been developed by the National Colorectal Roundtable. I think any of you who attended our last session and series with the Cancer Coalition around how to reinvigorate screening as well. We talked about this briefly, but Elsie and I thought it would be helpful to really share some of the ideas, lessons learned, statistics about what we're hearing. And then we're gonna spend some time breaking out in small groups today for about a 10-minute discussion about what's working from this resource, if there's ideas, things that you'd like the program to know. We're gonna dig into this a little bit, but then we'd love to hear from, again, these themes that they're talking about, what you think could be helpful. And again, if there's things that your clinic system or program or our program could help with really increasing screening, what it might be. So overall, the National Colorectal Roundtable is funded by the American Cancer Society. Elsa, myself, and others have either sat on the steering committee or are members. I really encourage you to visit the NCCRTC site if you have not. There's a lot of great lessons learned, best practices, and materials that can be used for people from all throughout the country. So we'll spin that as well. So this toolkit that was developed was really in response to the COVID-19 pandemic. And as all of you know, even better than us, when we saw screening plummet, the question of how to get people back in and screened again has been key. So thanks for those of you who shared your perspective in some of our other meetings, lessons learned, and then with our one-on-one calls, we've gotten a chance to hear from all of you about resources that you need, but we're gonna just dive into this tool a little bit further that the roundtable, several of the GI groups and partners put together. Do you wanna scroll down, Elsa? So overall, we know that there have been, we know that there are several safe and effective tests, colonoscopy, FIT FOBT, stool DNA, and virtual colonoscopy are definitely screening modalities that are all considered grade A on USPSTF and ACS guidelines. A reminder, that's for average risk population, but I think one of the things that's going to be front and center is that it's going to take all these types of screening modalities to us to get back to where we were and to gain ground based on the pent-up demand. So for the average risk population, we're a huge advocate of the best screening test is the one that gets done. Again, at this time, CCSP is not paying for navigation into stool DNA or FIT and FOBT or other type of exams, but we definitely support you. We're happy to do help with training or connect to resources. And if we do get a year-long extension, we will be talking to the health department about perhaps giving more time for people to navigate in this area. But I do want to just remind us that for people who are asymptomatic and average risk, even the stool DNA and FIT and FOBT programs are something that have been proven very effective if done annually. And that's something that we're really stressing right now is there might not be capacity for everyone to get a colonoscopy. There might be colonoscopy really kind of looking at prioritize for those who are symptomatic or a high risk. But we're one of the only types of cancer that have a couple different screening modalities. So let's really look at how do we use those other types of screening. We know that screening disparities are very evident right now. We absolutely know that in terms of looking at the medically underserved, specifically, that there's huge gaps, and that's really what CCSP is about and the work you guys are doing around the navigation. For those who are at high risk, and I just want to stress those again, and I think we heard this in the time of shelter in place. We do know people who are symptomatic, people who have family risk, who actually delayed significantly, and that's where we might see some of the highest rates of death. So I just want to remind folks, for those of you who are working on our family history component, those of you who are capturing family history, signs and symptoms, that if there is a capacity issue, even colonoscopy, really making sure those high-risk folks are getting in a timely fashion is something to talk to your medical team. And then overcoming those barriers. So really the work that you're all doing is around barrier reduction, helping with the psychosocial components, thinking about the other real barriers around access and transportation. We have resources. We cannot, ever reimburse a patient directly, but if you and your system have means for helping with reimbursement for childcare, or if someone needs money for gas, or if someone has an Uber or taxi and someone to accompany them, these are the things we can pay for. So these are our overarching messages. This is nothing new from what you guys all have done, but I just want to stress again that I have always been one who considered colonoscopy gold standard and sometimes am partial, but I just have to tell you, FIT and FOBT have a strong place in cancer prevention and control. And I think now more than ever, we need to understand that. And just a huge ode to the work you're doing, and what this program is about is really to addressing these areas. Okay, next slide. Which means scroll down. So assessment of the impact, this isn't lost on anyone here. What we know is that overall a 90% drop in colonoscopies and biopsies throughout the country. This is pretty standard. We know that there's probably going to be 4,500 excess deaths even up to date over the next decade based on delay in screening. We know that's a total of almost 2 million missed colonoscopies. And that's over nearly 20,000 estimated delayed diagnoses of colorectal cancer. So these are not Colorado specific. These are very trend oriented based on the entire US. But I think that what we know is right now is that this sort of pause has made a huge impact. And if this kind of pause happens again, we have to be really skillful about how we message to folks, how we consider, because these numbers will grow. So ultimately, we know right now these are the numbers that we're tracking. Elsa, myself, and our team are considering submitting something on behalf of the program to talk about a statewide approach and what all the experiences have been, so that we can share in one state what this has been looked like from a coordinated effort from the lens of navigation. These are the kind of statistics that we're really going to hear. So Elsa, I don't know if there's anything else that really jumps on to you at this page, but I just really think that this really identifies where we're at right now in the magnitude of the program and the problem, and again, why we need to really close that window. Elsa, anything else to add here?
I'll also just mention that the Colorado Rural Health Center put out a good report about the impact of when there was the elective procedures ban for a few months, that it really had an impact on the workforce and the operations of clinic systems across the state in Colorado and nationwide, and that it's really had an revenue impact on our clinic systems as well. And so that we completely understand that that's been a huge challenge with COVID as well. And so while we're able to screen people, it's really important, but a lot of our clinic systems in Colorado's need support to really reach all the needs of their patients right now because of those additional impacts that COVID has had.
And thank you for sharing that, Elsa. I want to also, to that point around the Colorado Health Institute has shared impact, I think specifically on FQs as well. We're going to try to use more of that data to make the case about advocating for more resources in your centers as we see opportunities coming forward. And the other thing I want to mention is we hosted a community webinar, and I think many of you were on, talking about the COVID-19 response. So just a reminder that the Colorado Health Department, Department of Public Health and Environment, and local public health agencies are looking for partners in the effort to help navigate in terms of looking at care related to COVID connected care, but I think they're even looking further at some chronic disease as well. So if you are in contact with your local public health agency or CDPHE, or can be, about what are those opportunities in response to COVID-19 for containment, as well as maybe even looking at vaccination approaches and how we're going to mobilize moving ahead, that's something for you to really consider, and we'll recirculate that information too. So also, I think you're right on. And I do want to say a huge thank to the Colorado Rural Health Center, CCHN, as well as all of our external partners who've helped really support the program and provide this data. So Elsa, I'll have you scroll down. Okay, so in terms of looking at what are the strategies that have been identified by the NCCRT that we're really talking about that that provide the public safe opportunities to prevent and detect colorectal cancer and polyps. And I'll have you scroll down also so we can see this whole page, or I guess up in this situation, sorry. Okay, so the alignment statement says that despite the challenges we faced during the pandemic, colorectal cancer remains a public health priority, and we must provide the public with safe opportunities to prevent and detect colorectal cancer and polyps. So what I want to say is right now, and Elsa, can you scroll down so I can see the bottom of the page, because it's got some resources listed, I think, on this one. Oh, no, not this one. I'll go ahead and have you scroll up. Oh, sorry, sorry about that. So right now, we have talked a little bit about the health priority and really thinking about folks who are disproportionate in terms of rates of colorectal cancer. And I do think that there has been a lot of attention around lack of access, particularly for Hispanic, African American, and then even for those who are Alaskan Natives, who have some of the highest rates in the American Indian population in terms of prioritization, and really thinking about how are we making sure to address specific populations for health and safety. I do think that along the lines of also risk stratification based on people's family history and signs and symptoms is something that we should consider as well. But I think one of the things is that forward facing, that management of ultimately understanding our risk of developing colorectal cancer and cancer in general, as opposed to being scared relative to the COVID-19 pandemic and really thinking of the virus, is something that is still considered something that I heard from all of you that we still need to really address, and really thinking about that balance between risk on both fronts. So I think that management of PPE, talking to patients about what that process is to make sure they're safe, that their providers are safe, and that messaging is definitely clear. This specific strategy talks about how do we align our efforts to make sure that there is a compelling answer for prevention and that patients do see that benefit. So ultimately, right now, again, we want to just make sure that we're really stressing that it's a public health priority. And I do think probably more than any time in history, we have seen our news media and channels really talk about the impact of cancer screening. So I have heard from many of you that while there are people who are scared, people who are managing that risk versus benefit of getting screened, given all of the elements of COVID, that there are a lot of folks that are also seeing that benefit, and how do we really continue to drive that effort. So alignment statement 1 really talks about that type of approach and something for consideration. Next slide, Elsa, or down to the alignment statement 2. So the other question is who should be that higher priority? And I've kind of mentioned that in alignment with also a good messaging about cancer prevention and control. Is ultimately that colonoscopy does remain safe, and that quickly reopening the country was a good idea, so that we make sure that we stress those who need colonoscopies and need this type of screening, particularly those who are high risk. is definitely something that we should strategize. So that I think that main point there is many people are reluctant to come to a health facility to receive care. Endoscopy units must be committed to a plan to address and ally and alleviate patient fears. So one of the things that I was going to say is that if you have questions about what the PPE policies, the testing policies are with your endoscopy unit, if there's anything that's changed, is there anything that the patient should know ahead of time, making connection with your GI team and keeping communication about what's happening now and if anything changes in the future is going to be critical. You are an active member of the team, and really knowing what's going on with your GI providers are going to be more salient as we continue to see fluctuations in what happens with the care and what we're moving ahead. I've been somewhat assured that, you know, we won't see necessarily another shelter in place or the elective procedure ban the same way. But I guess, you know, it's 2020, anything can happen. And so I think we need to just really think about how do we communicate and keep those open lines of communication. And then I think with alignment strategy 1, we also really need to critically think within our teams, also from a public health perspective, which is the type of screening modality that we really should use for average risk populations. And even if there is a time and shelter in place, if there is still an opportunity to do stool-based testing, follow up with people for chronic conditions, and really map out that plan. I do want to also just be really clear, of course, that if there are signs and symptoms, people need to be prioritized for colonoscopy, but there's still really good work and messaging that can occur even if another elective procedure ban does come to bear. So Elsa, anything you want to mention about these first two statements?
I think you covered the main pieces of that right now. I know that, and I think you touched on this a little bit, that COVID testing has been somewhat of a barrier to some of our clinic systems if patients have to travel twice to get COVID testing and then wait a few days and then get their colonoscopy. And so I think that that's something that in terms of resources, using transportation resources is something that is trying to address that, but clinic systems are being really creative about how to address that to get patients in for screening if they need a colonoscopy. And so that might be something for discussion in our breakout groups, just some food for thought. If your clinic system is requiring COVID testing before patients get a colonoscopy, what's worked well, what's been challenging, what are some new things you might try to address that?
Okay, great. And we'll drop down to alignment strategy number 3. And then, oh, sorry, this was the page I was thinking, Elsa. Just on page right above the bottom and then a page right before this. Okay. So one of the things I think also that has come out is ultimately when the elective procedure ban, as well as the reinvigoration of screening has happened, there's some key institutions that have given really good advice. CMS, Office of Medicare, has given some good advice and is considered an expert. AGA, American College of Gastroenterology, and the American College of Radiology and GI Endoscopy have given some really good advice and guidance. They are mostly in line with the CDC and with the health regulations. So I think if you have questions around what are safe practices, what is the state of what's happening with the GI practices, it's even sometimes I visit these sites to see even maybe what's coming and considered, some of the things that they're considering moving ahead. I think more than ever, they're putting front-facing statements out to the public about what navigators, medical providers, primary practices should be considering. So these are, again, some really good guidance spots for you, as well as the Centers for Disease Control. The program will try to do our best to definitely keep in contact with all of you about the updates as well. But if you have time and want to get some additional advice, these are definitely the societies to look for. The third alignment strategy is during a time when availability of elective screening colonoscopies may be lifted. that we really can be safely offered through at-home stool base. So ultimately, again, the stool DNA as well as FIT and FOBT are definitely types of advantages to take advantage of right now if performed on an annual basis. And I think we've said this through our training sessions around FIT and FOBT. For those types of tests, they have to be done annually. So if you plan to do it one and done, not good. There's no evidence that using FIT and FOBT one time actually decreases cancer mortality, but if done 3 to 5 years in a row, it can decrease mortality by 30 to 50%. So I'm saying this because I really think this flu season, there could be a huge opportunity when the COVID vaccine is available. There could be a huge opportunity. Let's look at those annual types of events where people come in that we might be able to go ahead and disseminate the FIT and FOBT testing so that we can get caught up on the backlog and again, make huge ground to still try to get to that 80%. The other thing I want to mention is stool DNA. More and more Medicaid programs, as well as private insurance and Medicare, are starting to cover stool DNA. We are also in talks with Exact Sciences that if we can put together a study design fairly soon, that we might look at donation to the program for the Cologuard, which everyone's seen on television. It's really the best thing since Katie Couric for promotion of colorectal cancer. So we will be connecting with Exact Sciences further in the months coming about possibility. They've made no promises, but this is something we're going to consider. What I want to say about the stool DNA is this: that test has to be done every 3 years. The FIT and FOBT tests, which are guaiac based, that are not DNA focused, but are still looking at hemoglobin in the blood, they are every year. A stool DNA type test will actually give you some lead time where a patient doesn't have to have a colonoscopy every 10 years and they're not doing a FIT or for FOBT annually. The stool DNA gives that opportunity for every 3 years. So that's why I'm a huge fan of it, because of the sensitivity and the like. So this is something we're going to be considering, but I think it's really worth getting some time and to know if patients' insurance plans can cover, because this could be a really good attribute. I do think that they're ultimately looking at when the procedure ban may be limited because of COVID-19. I think I said lifted earlier. Again, this could be a really good opportunity for you to consider capacity. Okay, I'll have you scroll down. And just if you have any questions again about FIT and FOBT programs, we do have the FIT and FOBT series, which talks a little bit about population management, the best tests to use, how to follow up and the like. But again, just a reminder that if someone is found to be positive, they will have to have that follow-up colonoscopy. And that's something that really should be considered when doing these types of tests. Okay. And I do think the one thing that was at the bottom of that paragraph is that right now, thinking about COVID and people contracting COVID, it is important to note that there is evidence that the virus is shed in the stool, although most evidence suggests that it's not shed in a viable and an infectious form. So that ultimately, if people are handling stool and the like, they should be very careful with PPE. So this is one of those sort of situations where we have to be really careful because it is a body substance. But I think the other thing is that most of the time the patients are handling the fecal matter and the shipment for the sample themselves. But on the receiving end, the people who are analyzing this, or if you come in contact, just like all biohazards and all blood and human tissue, we have to be very careful. The other thing I just want to mention too is that there's also been this misnomer that that contracting COVID-19 will happen for people who are getting their nose swabbed and the like. Those are very that's probably not happening. So I think we have to dispel a lot of rumors and myths about how COVID is also contracted. So some education around that, around fecal matter, as well as also understanding even the COVID-19 testing itself causing COVID-19. Dispelling some of the myths and rumors are something most of you are already dealing with, but these are some of the things we're hearing as well. And then the fourth alignment statement is really around gaining momentum and reigniting screening through public messaging, highly dependent upon local regulatory requirements, public health efforts, and policy change. So I want to stress this because I do know that, of course, and you all know that Colorado is a local controlled state. Governor Polis and the governor's office, as well as the health department, have set a strong edict about mask wearing, about the different initiatives in terms of neighbor protection, shelter in place, safer at home. And there are times where the state will definitely take the reins in talking about what Colorado will do and mandate, but there is a lot of variance based on local control. And so in Colorado, the local public health agencies will control the jurisdiction in a way in terms of implementation of programs, policies, and ultimately what's happening in terms of elective procedures, what's happening in terms of people being able to utilize certain public services, when people can come to specific public places and the like. So these are things to really keep in mind. And again, that connection with your local public health agency, your medical team, and understanding what are the requirements that can be very different with in all the different states in the country, but it also is very different sometimes state by state, or excuse me, county by county in Colorado. And I think more on the enforcement side can be very different as well. But I think that makes a huge impact in terms of how are you messaging to patients and what kind of information are you sharing. So these are the guidance. There's some specific connections here that talk about some of the requirements. So realizing that simply reopening is not enough, messaging to patients about cleanliness, what's going on. A second requirement is local response efforts. So we need to think about how we think about that again in those specific areas. And then the third area, I think those are the main ones right now. So we're going to take some time just to have you guys break out into small groups for about 8 minutes. And we'd love to hear, again, some feedback from all of you about what are some of the things that you're experiencing of these 4 alignment statements. What are you thinking about and what do you wish to share? So we'll have one person in the group, go ahead and share when you come back and type out what are the key things that you're thinking in the chat. But we're going to have you guys break out into small groups over the next 7-8 minutes to have some sharing of perspective, and then we'll come back and close out the meeting. So Elsa, any instructions?
I put everyone who said they had phone and audio connection all in the same room because it wasn't easy to figure out whose phone numbers went to who. So you'll all be in the same room, so hopefully phone should work. And there is going to be 5 groups of about 3 people, so I will go ahead and open those up. And I'll let you know when have 1 minute left before I close out the groups. All right, and you just have to accept the invitation to move into that breakout room once I hit open. So on the count of 3, I will open up the rooms. 1, 2, 3. So Andy, are you thinking at 12:55 we bring them back?
Yes, 12:55 or 12:54, something around there.
Okay.
Oh,
I don't know how you do Zoom meetings all day, every day.
oh my gosh. I got a note from Rich Goldberg. One suggestion that he has for future is to devote 10 to 15 minutes to clinical implications.
Mm-hmm. I think most of the time focused on disparities and all, and that was good, but people also try to just ask any question they have related to early age onset.
Mm-hmm. I thought Andriana's data was intriguing.
Mm-hmm. Yeah, it's interesting to see some data from Nigeria and Indonesia because I can't say I've seen much data outside of Europe and the US.
You know, it's funny. I saw the Indonesian. Oh my gosh, I'm such a mess. I saw the Indonesian data right before I went to Asia last year. And I thought the island of Java actually has some of the highest rates in the world. It was
Wow.
crazy. Mm-hmm.
Any armchair theories as to why?
No, no. And Jose was actually supposed to speak a little more about that, but I think that formal time is a good idea.
How many minutes did it go over with him talking about? I didn't know with that research he was gonna like do more than with the like 2 minutes left go into like the full 3 slides of like one piece of research.
Yeah.
You would think you would just do quick high level when you see there's 2 minutes left, but you know.
Yeah, he doesn't, yeah. Yeah, it's crazy. He's such a good guy. I just find myself getting anxiety when I have to talk to him.
Mm-hmm. Yeah, he's a great guy and he's very engaged in the work, but it's a little hard to follow.
Especially because sometimes I don't think he gets I mean, what would have been helpful, and I think if we did something with Whitney and Samir, they would make it really dynamic.
Mm-hmm.
Like if Samir would present and then Whitney would do it.
Yeah, that could be one of them. They would
Mm-hmm.
be a great duo.
Yeah, they would be really good. And the key, so, but I don't know why Jose just brought more slides.
Mm-hmm.
So that was a little funky. Um, I got a $6,500 bill for all that stuff that happened this spring.
Wow.
Like, I know, and it didn't really come as a bill, but it's like a statement from your insurance, you know?
Mm-hmm.
And it's just giving me like the worst anxiety.
Yeah, in the US, even with good insurance, you can get surprise bills anytime.
I'm gonna end up homeless from this. Just kidding. But I know, I'm just like, what the fuck are you talking about? I couldn't sleep last night. I got all upset. I got like crazy upset. And then I started thinking about, yeah, like how it is for other people. And at the end of the day, I'll find a way to pay it. But good God, hopefully it's really not that much. But I swear to God, when they asked me about it, I just asked them, but you know what? Like I had already had pain meds at that point. Like
Right.
I remember them talking about it, but I wouldn't have signed on if it would have been $6,500 out of pocket.
Yeah, I feel like sometimes they're good about disclosing costs, but a lot of times people just in the clinic don't really think about the cost.
Yeah, and I remember asking her, so I went onto the site to look at the testing and stuff that I had, and it said like, if you make this amount of money, it'll be $150 out of pocket. But I'm like, okay, so I make twice that much, right? At the highest end. Even if you like multiply that, I would still be happy to pay $500 or $1,000. I just don't want to pay $6,500. Like that's excessive.
Mm-hmm.
So I don't know. I'm not
Definitely.
saying I don't need to pay anything, but there was no lab in network who did that kind of stuff that I needed.
Right. Yeah, I feel like the US healthcare system just makes it hard no matter what.
Yeah, it sure does. All right, should we
Okay,
bring
I'm
people
gonna
up?
close the rooms. I'll put the survey in the chat because I don't think we're really gonna have time to talk about it.
Okay. By the way, that's a kick-ass picture.
Thank you. I'm looking forward to fall leaves.
It was nice this morning.
It was, and last night was really nice not being hot.
Yep.
So they should be coming out. You want me to stop sharing?
Yeah. Okay, everybody. Thanks so much for those who stayed on. I got to tell you, if there's ever a breakout session, I'm always not necessarily the best group discussant. So thanks for playing along. I think we've got most everybody back in. I think we lost a few earlier. We're going to go ahead and just get started, but I'd love to hear, Elsa, let me just say before we get going in discussion, because we have about 4 minutes left. For the survey, you're going to go ahead and pop that into the link and then send it out as well. Is that right?
Yes, we won't have time to talk about opportunities for training and sustainability collaboration today. So please fill out the survey. There's some ranking of different opportunities. And if you have any other ideas, please put them in the survey as well.
Good. And Elsa, with this data, we can probably share at one of our next calls and have more dedicated time. So
yes.
Okay, great. Let's just have a quick, I'd like to hear from two groups. Is anyone willing to share some of the things that happened in the discussion? Anybody?
We will call on people, so.
This is Laura.
Hi, Laura.
Hi. I only had one other person in my group. There was another person, and I'm not sure what happened to her, but we basically just touched base on what's happening here in the San Luis Valley. So we have a general surgery department here. We don't have a GI here, but they have started with the screenings probably mid to late July. What they're doing is trying to get those that were scheduled for colonoscopies prior to the COVID but they're also focusing on those that are high risk and symptomatic. They do the consultation via telehealth, and patient has to go in a day before their actual procedure to get a rapid COVID test. So that's
Awesome.
where we're at here.
Awesome. That sounds great. Thank you for that. And let me just say, from any of those alignment strategies, Laura, anything particular that like came up for you that would be sort of new to what you guys have been thinking, or did that, what NCCRT put together, was that pretty much on point about what you have been doing?
It appears to be pretty much on point, yes.
Good. All right. Well, thanks for sharing.
Sure.
Anyone else wish to share? Okay. So guys, we are just a couple minutes before the top of the hour. And I want to just say thank you. I know we had some updates today, a good chance to check in. Elsa, do you want to share in terms of what we're going to be doing at our October meeting and moving ahead in terms of Denver Health is presenting, correct?
Yes, so for our October monthly call, as we're at the end of the first quarter at that point, Denver Health has been doing a lot of work on their sustainability plan since they started at the end of the first year of the grant cycle, really making the business case for sustaining their navigator position, Diogo from Denver Health. So Diogo and his supervisor, Michael, the operations manager for the GI lab at Denver Health, is going to be really sharing about exactly what went into putting together their sustainability plan and the business case. And they should have some updates by that point about what happened when they brought that to leadership. And so for those of you who are trying to think more about sustainability and how to keep the work going this year, it will be a really great opportunity for some clinic perspective, and will allow some opportunity for discussion at that point.
Okay, everybody. Well, thank you so much for joining us. Have a great rest of your afternoon, and we'll talk to you soon.
Thank you. We'll send out the follow-up notes today or tomorrow.
Thank you. Bye.
Bye-bye,
Thank
everyone.
you.